So this is about all these new different drugs and how they might work. And we recently had this small interfering RNA that's been launched. And I'll tell you a little bit about the evidence, or lack of evidence for a lot of it that is coming. But to start off with, here's the first question. The question I've got there is there any real evidence that in patients with diabetes that we should go for good glucose control? So here you go. So most of you have correctly said that there is now good evidence, and two of you think that we're just guessing. Okay, so here's another question then, right? So supposing you develop type 2 diabetes today, and you decide to be really aggressively controlled as opposed to somebody who's less aggressively controlled. How long will it take? There's 4 options there, A, B, C, or D. Okay, so how long after I start improving control will it take to have benefit? Okay, does it take a year, 5 years, 9 years, or 15 years? And this question was answered by the UK PDS, which randomized patients to good control and normal activity. How long do you think it took before they could see a divergence in the outcomes for these groups? So most of you have gone for 5 years, followed by 1 year, and then I think only one person has put the correct answer of 15 years, okay? So it takes a long time. And so people might think, what is the point? And I'll show you what the point is. So this was a very old study, the UK PDS. They took from 1977, when we were very early on in our management, we only had basically metformin and gliclazide, okay? We had the option of insulin, of course, but they took 4,000 newly diagnosed. So these people basically at the point of diagnosis would have had pretty low risk of dying and pretty good coronary arteries. And some of them were randomized to conventional diet, and others were given intensive glucose control with what they had at the time, which was sulfonylureas, insulin, or metformin. And the metformin for overweight people. And they followed for 10 years. Okay, on average. And then there's a second really interesting part, an important part of the study that happened afterwards when they finished the study. They just did some monitoring. So what happened? So first of all, they did pretty well in terms of the intensive control had an HbA1c 1% lower than those given conventional treatment for the whole 15 years. Okay, so the intensive were reminded repeatedly and were meant to be compliant and were aggressively treated. And there was one of the big centers at Hammersmith was running this study. And then you look at events, and I've covered out a bit up here, but for now you can see that there were no real difference in the event rate between those managed conventionally and those managed intensively up to 9 years, and then it started to diverge. Okay, so you start to see that people who have conventional treatment have a higher risk of various endpoints. There's several papers came out of this in the Lancet. But basically everything started to get bad at about 15 years. And then lots of things were bad. So whatever you looked at, they did worse. Any endpoint, microvascular, retinopathy, albuminuria, even mortality, right? So that was very clear for the first time that if you develop type 2 diabetes and you have tight control for 15 years, you will start to reap some benefit at that point. So then the people say, well, what's the point? 15 years. Well, it's more interesting because what happened after this is quite important, because what happened then was they published that, and then the study's over, and then 10 years later, they went and reanalyzed the data and looked at the patients who were still available. So here's the key thing, right? Of those people, they did post-trial monitoring of 3,700 people. And the key thing is no attempt was made to maintain their aggressive treatment, what they were assigned to, okay? So what do you think happened to their glucose levels? Well, I'll tell you, okay?
The red group were the intensive control 1% lower, and the blue were the control group. And you can see that they trended together. So the tightly controlled basically gave up, and the not well controlled remained not well controlled. But everybody then slowly got better as we got new drugs and learned. So we were all told, oh, we really have good evidence now. So the A1C came down in the country generally, okay, because we started using newer drugs. But the difference disappeared. So what then happened to the control group, and what happened subsequently to their mortality? Well, this is really the key thing, okay? And what happened in the 10 years after the study was over was that the benefit got better and better and better. And this is a very key point. The p-values in everything you look at was very, very much more significant than the first paper. So this was published 10 years later, and showed that all these endpoints, people who had intensive therapy did better, highly significantly, than the control group, the conventional therapy, even though they weren't being managed separately now. So what this showed was that there is a legacy benefit. In other words, if you have tight control for 15 years and then give up, you then continue to have benefit for the subsequent years. Now, this makes sense. When you get diabetes, you start further up your coronary arteries, but you're okay. And you only have a problem when you have an infarction. So it furs up and furs up and furs up, and then you give up. And if you have had tight control in the 15 years, you've got a better coronary artery, so it's not furred up. And so the benefits then are very profound and long-lasting. So the message is we need to get patients with diabetes to be well controlled right from the start, and they will benefit for a long time afterwards, but only after a long interval. Okay, that is the summary of the UK PDS. Now, I'm telling you this really to compare it with what's going on now with all the newer drugs. Okay, but bear in mind, it takes 15 years before good glucose control has an effect on your death rate. So then in 2008, a number of other studies, I want to show you one of them, ACCORD, which was, they've all got great acronyms, okay? Action to Control Cardiovascular Disease and Diabetes, ACCD, ACCORD. So they took people now, unlike the first study, they thought we can't wait 15 years to prove these drugs work. We need people who have already got knackered coronary arteries, and then randomize them to different types of treatment. Okay, so ACCORD looked at a drug that has now been banned called rosiglitazone, which was very, very widely used glitazone, thiazolidinedione, and it basically did improve glucose levels. And they really were very aggressive with half of them. Okay, so it was a randomized study. They took patients with type 2 diabetes who had poor control and had already got bad coronary artery. They already had an infarct, for example. So this starts in about 2006, I think, and they randomized them in the same way the UK PDS did, one tight control, but this time now we've got a few more drugs. This is when Rosi and parglitazone became available, okay? And so they used those drugs to really push down the A1C, and it worked. They really had a good effect with these extra drugs in dropping the A1C. And it did prevent a number of events. So that statin therapy, here you are, this is after 6 years, you start to see divergence. But, death, wrong way around, okay? So what was a bit of a surprise was that although you do start to prevent stroke or MI, you actually have more deaths from any cause in the intensive group, which was a bit of a surprise. And so this came out in the New England Journal. At 1 year, the A1C was better, they achieved good control, but at the same time, 257 patients in the intensive group died compared to 203, and they therefore had to stop the study because it was highly significant. They found there was more hypoglycemia in the tightly controlled patients and had a lot of weight gain. So this was a surprise, and they called it increased mortality, unrecognized harm. Now, with hindsight, we're thinking these guys have already got blocked coronary arteries. If you drop their sugar tightly at that point, you're going to have basically sudden death, which is the only thing that can explain the difference between the death rate and the other morbidity.
So here we've got a problem. We know that if you have type 2 diabetes, you must have good control at the start. But after you've got bad chronic artery disease, you need to let up a bit. Okay, that's really what the message is. And the other thing to say is that you need to avoid using drugs like rosiglitazone. Here's my key second message. Early on, you've got no complications. Tight control is really important. When you've had it for many years and there's atheroma everywhere, tight control can cause probably arrhythmic death. That seems to be the difference. So if you've got elderly patients with established disease, you need to change your targets. And we do that. Okay, we've learned these messages and we do that. So after that came out, then it was clear that rosiglitazone seemed to be one of the drugs that caused heart failure. So both rosiglitazone and usable have now disappeared, but it was basically banned because it was blamed for the heart failure, and that seems to have been the case. Okay. Now, rosiglitazone was very heavily promoted by GSK. In fact, the reps used to come to Hammersmith and Charing Cross and try to sponsor lunches all the time. And as a consequence, they were one of the best sellers, 2.5 billion annually. Now, of course, they've been taken to court for some millions, but they've made billions, so they're not bothered. So to summarize, they did improve glucose control, but increased death. And the drug then got banned and withdrawn, but by that point, the patent did expire. So they've made their money. So from a drug cost financial point of view, they've done really well, okay? But what came out of that was the American and the European Society for Study of Diabetes all said, we've got to stop being so glucocentric, and we now need to look in all drugs at CVOTs, cardiovascular outcome trials, and look for major adverse cardiac events. So that was a change, and it was put into FDA regulation that before we will license these drugs, we won't make the mistake that we did with rosiglitazone. If it kills people, despite a good sugar level, we can't approve it. So as a consequence, I'm going to show you some data from the newer studies that all came out of these large randomized control trials. Now, they're very expensive to do, but they've been very good. But to summarize where we are at this point, is 2010, we have the DCCT that randomized type 1 diabetes patients and proved that it was a good thing to do. I'll talk about UKPDS, and then a core that says, if you suddenly tighten control, you can kill people. So at that point, we were getting newer drugs. So this was now 2015, and it was clear that metformin was a winner. So everyone gets metformin unless contraindicated with type 2 diabetes. And then they said, you can add any of the below. And the evidence between them was very scanty. We had lots of data for sulfonylureas because of its longevity. Rosie's, this purple one, got banned. We've just got pioglitazone left, but that's not going to last very long. So new drugs we've now got are DPP4 inhibitors, Sglt2 inhibitors, and a lot of people have talked a lot about this, and Andrew Frankel did a very good staff round last year about their renal effects. I'll just summarize that briefly too. And then there's the GLP-1 agonists, which were very heavily involved with research at Duquesne Road in the past. So these three drugs are relatively new and compared to all the other old ones. And we're now looking at which of these should be using and in who, which is the best drug for at this point in type 2 diabetes. So let me just explain or remind you, because I hope you know this. So GLP-1 analogs, a lot of data came out of Hammersmith in terms of how they work. They come from the gut and they tell your pancreas that you've had a meal, and they stimulate insulin secretion after a meal. And also, they have a direct effect on appetite and gastric emptying. So you feel full when you make GLP-1. There's control of appetite. And so we were involved in the research in 1996 in animals looking at one of the analogs of GLP-1 called exenatide, or it was called Exendin-4, in fact, and the drug that came out of it was exenatide. So just to quickly summarize how it works, you eat a meal, it goes to your gut. The first phase insulins happen, but also the gut then releases GLP-1, which stimulates your beta cells to make insulin and less glucagon. The GLP-1 that you make is broken down by DPP4, okay? That's dipeptidylpeptidase 4. And if you block that with a gliptin, you can then make the GLP-1 last longer. Okay, so you have a GLP-1, which is a peptide, and therefore an injection, and then you've got gliptins that are oral that make your own GLP-1 last a bit longer. So that's DPP-4 inhibitors and GLP-1 receptor agonists covered, okay? And so the first of these was exenatide, which was an injection that patients took, and it basically stimulated their own insulin secretion, and we've now got a few more. There's more and more coming on the market, and they're pretty effective. They are being licensed both for diabetes control and weight control, and the weight control option is very expensive, okay? And they're very effective. Semaglutide looks like a bit of a winner for weight loss, and they're available. We need CVOTs. Here they are, okay? So liraglutide, we're not going to say it drops blood glucose. We're going to do a randomized 5-year controlled trial starting in 2010, published in 2016, showing that if you have injected liraglutide, you have a lower risk of dying of a heart attack compared to placebo. So really good studies have come out of this, but very expensive. So this one was called LEADER, and all of these trials have got fantastic acronyms. So LEADER is one of them. And they look at, whenever you do this now, you get all-cause death mortality looking at improved high significant p-values, cardiovascular death, myocardial infarction, and so on, okay? As long as it's significant in the key bits, you get a license. And then everyone else follows with their own drug. So Sustain-6, okay? This is semaglutide, another analog of GLP-1, showing that you get, after several years, okay, they start off together and they slowly diverge over time. And the semaglutide reduces mortality. We're quite happy with that too. So GLP-1s get a tick in terms of use. They help you lose weight. They make you more insulin. They make you make more insulin, and they prevent death, which is what matters. So they're better than these purple rosiglitazone group. Okay, I won't say too much about Sglt2 inhibitors, but I will cover a bit of what Andrew Frankel said. So the first of these was empagliflozin, and they randomized patients to that or placebo. And just to remind you how it works, it blocks the resorption of glucose in the renal tubule. So we all filter glucose and we all resorb all of it. So in our urine, we have no glycosuria, no glucose. And if you give someone this drug, you make them pee out glucose. Now, when I started in diabetes, that was the last thing you wanted. The whole point of treating people is they don't have glycosuria. So I didn't think it would catch on when it first was talked about. But I'll tell you, it has been a major, as I'm sure all of you have heard, landmark effect. So I'm going to show you the data now. So the drug basically makes you pee out glucose and a bit of sodium. It's an osmotic diuretic as well, clearly. So the study, EMPA-REG, randomized 11,000 patients, big international study, randomized patients to placebo empagliflozin in 2 doses, and they looked for major adverse cardiac events, okay? And I'll just jump to the results, really. It's quite amazing. So this is what they found. The A1C drops pretty quickly by 12 weeks because the red cell lasts 3 months. Both doses, and there's placebo at the top there. Weight goes down because if you're peeing out glucose, you're losing calories. Your weight circumference goes down, therefore. Your blood pressure falls because if you've got an osmotic diuretic, you become a bit drier. Both blood pressures, systolic and diastolic, fell, and the heart rate, luckily, didn't change. So then they started looking at the primary outcomes, and you can see that it looks pretty good, okay? There's less major adverse cardiac events in the EMPA group than the placebo group, okay? And that's pretty reasonable reduction over 4 years. But this was the really interesting thing, because remember I told you at the start, it takes 15 years before you see a drop in mortality. This is magic. This is 6 months since you start. It diverts right at the start. You see an increase or a decrease in cardiovascular death. So it's not working through glucose. It's saving lives way before that, okay? So also so if you look at heart failure, okay, or cardiovascular death, you see some pretty good outcomes. And there's as they would, everything. And basically, it rapidly reduces death, but especially in patients who've got heart failure. So This is hospitalization for heart failure at the very start. So with hindsight, I'm saying they didn't expect this. They were looking for a long-term outcome in patients with diabetes to prove they weren't killing people. But to their amazement, it did a much better thing than that. It actually prevents death very early on, preventing hospitalization for heart failure. Now, obviously, this is, with hindsight, due to the fact that you're on a diuretic. So really good outcomes, and then renal effects. So you've got glucose in the tubules. We all worried it would cause renal failure. At the very start, we're told, stop these drugs in patients who have a rise in creatinine. But in fact, it looks pretty good. It seems to prevent nephropathy. This is because I'm saying now that we've got a glucose in the tubule. And then a bit like ACE inhibition, when you first start it, okay, at the very start, you see an instant worsening of the GFR. But in our diabetes patients who, in the control group, you see diabetes relentlessly makes your renal function worse and worse and worse over 5 years. This, like ACE inhibition, makes things look bad at the start, but if you keep going, you maintain your GFR. So prospective randomized controlled trials show that this drug keeps your kidneys going. How does it work? Lots of possible effects. This was published in 2016 when they're saying, it's amazing. It magically does this. We didn't expect this. We were doing this study for safety. So really, it's pretty cheap in terms of it's preventing deaths because only 100 people and you're going to save mortality. So it's really pretty cost effective, okay? And you get benefit on your kidneys and you get benefit on your heart. And this is about 5 years ago because things have gone a lot further since. So of course, after empagliflozin, all the other flozins join on, okay? This is a couple of years later now, and they've all got to do randomized controlled trials as necessitated by the European Agency of Diabetes, the EASD, and also the American Diabetes Association. So the FDA have also insisted on these big trials. So dapagliflozin, same thing, big randomized controlled trial, and A1C falls, as you'd expect, weight falls, and they see all the same benefits in terms of death rate over long periods, okay? So whichever flozin you choose, dapagliflozin, empagliflozin, this is called the DECLARE study, okay? Dapagliflozin looks great. Canagliflozin, same story, okay? So all of these drugs, there seems to be a class effect quite early on, improve your survival, and this is a study combining all three meta-analysis. EMPA, CAN versus canagliflozin, DECLARE is dapagliflozin, all of them improve outcome in terms of heart failure. So heart failure alone now, it seems to be an indication for using this drug because this drug was licensed for patients with diabetes. Now there's a huge market if we can go not just type 2 diabetes, but there's the renal world and the cardiac world. So that's what they've done, okay? So we've got EMPA, DAPA, and canagliflozins, and those are the 3 studies, and they've all shown good benefit. That's in type 2 diabetes, okay? Now what about type 1 diabetes? Now if you've got a drug that's good for your kidneys and good for your heart, presumably we can use it not just in type 2 diabetes as a glycosuric, but actually we can use it in type 1 diabetes. So this was a study called DEPICT-1, and this was done for dapagliflozin in type 1 diabetes. Now, I will say there was a signal that we got that dapagliflozin means that you need to have less insulin, and that seemed to precipitate some patients developing life-threatening DKA, diabetic ketoacidosis. So that was known about, but this study was done, and these authors, that was the first author, Dan Donut, was at the Hammersmith when I was an SHOs, but he's moved to the US and he's running this large study. And you can see that there is a good outcome, okay? They lose weight, and they looked at lots of different other outcomes, and the benefits were quite clear in this study. So at this point, they were going to say, we've got a drug for type 2 diabetes, let's also include type 1 diabetes. Not a huge market compared to type 2, but still, we should give them the benefit too. And they need to have less insulin. They have less severe hypoglycemia with dapagliflozin than placebo. And so they were going to apply for license, and dapagliflozin was approved in Europe for type 1 diabetes as well. But the FDA said no, okay? The FDA did not approve it. It was only approved in Europe for type 1 diabetes, but the FDA said only for type 2. And they have known, okay, that the exception of the higher number of DKA events in the patients treated with this drug. It's known about, okay? So we know that. So we need to choose our patients carefully. We can't just give all type 1 diabetes patients this drug because it will precipitate some patients to have DKA. But there are some, and in the subsequent paper, they were looking at patients with a high BMI who could benefit from losing weight, and patients who were less keto and well educated and had not had DKA. So that was going along, and various of those DEPICT studies were going on, looking at type 1 patients. And then, of course, I've mentioned the fact that we can treat patients with heart failure and renal disease who've not got diabetes, okay? So here we go. There are a number of studies. This is one of them, DAPA heart failure, randomized and unquestionably beneficial in patients with heart failure, whether or not they had diabetes, okay? So DAPA was better, highly significant in non-diabetes patients. So last year, DAPA was licensed and NICE approved it with an evidence-based recommendation to start dapagliflozin in patients with heart failure with a reduced ejection fraction. Renal, same thing. I won't say much more about this because it was very well covered by Andrew Frankel last year when it was just fresh, but this is now a year old. And again, randomized DAPA to placebo in patients who had renal disease, who did or did not have diabetes. And basically it worked in all of them. There was basically good renal outcomes, less renal failure, less end-stage renal failure. So they started that study in 2017, and then the data monitoring committee said, you got to stop because it's really effective and we can't give placebos to the people who are not getting it, okay? So by 2020, we knew that renal patients should get this drug. So their conclusion was, in patients with CKD with and without type 2 diabetes, dapagliflozin compared to placebo reduced kidney failure, reduced death, and prolonged survival. So that was quite clear. And again, this year, last month, it's got its approval for treating chronic kidney disease, evidence-based, good reasons for using these drugs, okay? I remember I said earlier that 3 years ago, this is March 19, DAPA was approved for type 1 diabetes. So they applied for the license, and the NHRA said, fine, but if you do this, we need to warn people there might be DKA, so we need to put a black triangle in the BNF against dapagliflozin. And so, and this is terrible, I have to say, and so the drug company, because of commercial interest, decided to withdraw the application for a type 1 diabetes license, okay? And so AZ withdrawn the license, and they said because of fears that the required changes to the black triangle would cause confusion amongst us when we prescribe it for other conditions. And what they mean, of course, is that the black triangle would, against DAPA, would mean we would use the other ones. There's EMPA and CANA competing. Despite this black triangle not being uncommon, AZ said in its withdrawal announcement that the changes might cause confusion among physicians treating patients with type 2 diabetes, okay? So pretty shonky in my view. This is this year in the BMJ, and they're saying we need to withdraw the license. Now, this is very unfortunate because the outcome of withdrawing a license means it gets very well published, and now it says no longer authorized. Now, that's quite strong because it basically means we're going back to prescribing it off patent, but it's not just that. It now says in big letters, no longer authorized. So that means if I prescribe it for my type 1 patients and something happens, they'll say, oh, you have a drug, it's not just off license, it's not authorized, but that's all that means. And they do say here, they've withdrawn it. The removal of the indication is not due to any new safety concerns. So it's entirely financial, really. But that means that our type 1 patients, because it's such a small part of the market, are not going to get the benefits on their kidneys and heart that the type 2s and the non-diabetics will get. So I've got a whole other section to talk about though, but at this point, we're talking about treating patients with diabetes, and we're saying that all of them, we should think about adding empagliflozin or liraglutide because they've been shown to reduce all-cause mortality, okay? And so looking at these three drugs, in fact, we did a meta-analysis, and if you meta-analyze drugs that have had a randomized control against placebo, it's quite tricky. And so what you've got to do is get all the original data and then do a comparison that enables you to cross-compare different drugs, different classes. And to summarize, we've basically found that the Sglt2 and GLP-1 agonists were very effective and the DPP-4s weren't. So I think they're going to fade away. They'll be used in people who don't want the injections. They have got glycemic benefits, but they are not as good as the Sglt2s and GLP-1 agonists, which is what the outcome of this paper was. This was now 2 years ago. Okay, so I'm going to just move on now to some non-diabetes risk factors in the next 15 or 20 minutes, and I'm going to ask you another question. So I know there's only two options, A or B here, right? So supposing we have now a patient who's 76 years old, who's had a myocardial infarction, okay? So he's definitely got vascular disease. He as far as they've not got diabetes, his blood pressure is 140/80 on atenolol. And his LDL is 3 on atorvastatin 80. So the question is, what should we do now? Okay, he's had a myocardial infarction. You've got either A, carry on the atenolol, or B, keep on the atenolol, but add a thiazide to really push down that blood pressure. So by a small, not a huge margin, by a small margin, more of you will add a thiazide and be intense. And that is the right answer. And I'll show you the evidence because that's what we need, okay? It's the evidence. So this was a sprint study published in 2015, and they took exactly this kind of patient. The New England now have these nice graphical representations of how it's done. They took 9,000 people, they randomized them, they had already had an MI, so exactly that patient I spoke to you about. And half of them were given basically an added treatment with a thiazide, and they looked at death from any cause as a secondary endpoint. So the protocol encouraged thiazide diuretics. I'll just summarize that briefly. They could use other things. And the outcome was pretty good. The intensive control, they got down to 121 systolic, and the control group, they were running pretty well at 136 systolic. However, they stopped early because the people who had tighter control had a lower death rate, lower composite outcome, and it was significant. And so they had to stop at 3.5 years. Okay, and here's the data that shows that intensive treatment basically reduces your chance of having a further infarct or death from any cause. Okay, quite a significant reduction. Absolute of 2%. So if you give a thiazide diuretic to 100 such people, you will reduce 2 events. That is it's very cheap, very, very cost effective compared to what we do now. And so basically much, much better than what we've done up to now. So it's really worth doing. So really, we need to really optimize our medical treatment aggressively with statins, optimize blood pressure control because thiazides are almost free. And if they've got type 2 diabetes, treat that appropriately, as I've just told you. So there's my quick thought about what the message is at the time. This is what we're told. Aggressive management of blood pressure and lipids improves survival. Is that really true? So what would you do next? Okay, I'm going to give you the same situation, and I want to re-poll you, and I know that it sounds like I've got a loaded question here. Okay, so option A is leave on the same treatment, and B, add further lipid-lowering treatment, such as the Pcsk9 inhibitor. And it looks like some of you want to give lipid-lowering agents. So there's two things. One is that industry has spread around this thing about statin intolerance, and we're getting more and more evidence now that statin intolerance is a nocebo effect. In other words, when you tell people they'll feel aches and pains, they feel aches and pains. What else can you do? You can either use a monoclonal antibody against PCSK9, And now, quite recently, there is inclirisan, which is a small inhibitory RNA against PCSK9. Now, of course, they had no evidence for any of these drugs until recently, but I'll show you some evidence now. So first of all, what is PCSK9? Okay, well, PCSK9 is that red protein there that regulates the LDL receptor, and it targets the LDL receptor for degradation. So if you remove it, okay, or in patients who had loss of function mutations, they seem to have a lower LDL. So we thought if we can physically remove this PCSK9, you inhibit it, then the LDL receptor is recycled and brings down the LDL further. So by removing PCSK9, you can reduce the LDL through this mechanism. So this is a protein that's probably evolutionarily there to regulate, because LDL, maybe in the days when we're starving, was quite a good thing. But what happens is if you give someone a MAB, evolocumab, you get an amazing fall in LDL, okay? So you give them a statin down to 3, and then you give them evolocumab, and it shoots down to just over 1. I mean, really aggressive treatment, okay? Amazing, really. Does it work? Well, let's do the randomized control trial. And so this was the publication of that. Does evolocumab reduce major events in patients who are on statins already? And again, they say to examine the tolerability and safety. And they randomized patients to, these guys were not very hyperlipidemic. Their LDL had to be just 1.8, okay? And they were put in this trial. They were randomized to placebo or either 2 weekly or 4 weekly injections of evolocumab. So it's an injection that you give once a month or every 2 weeks. Huge study, international, and there are 13,000 people in each group, okay? And these are people who had already got vascular disease, so they are high risk of dying already. And the LDL, here they are in the placebo group, they're already on statins because they've had an MI. The treatment group went down to less than 1, okay, really, really low LDL, so very, very potent, aggressive treatment, really low LDL. And their primary endpoint, as you can see, they've got a 2% reduction after 3 years, okay? So maybe it is effective. But, look at the y-axis. It says death, MI, stroke, hospitalization for unstable angina, or revascularization. So what they've done is they've put lots of them, because when you look at death alone, no difference, okay? So that was a problem. So they didn't put, this is my line, okay? I looked up the data and put in the death. If you have death on the y-axis, it doesn't work. But it seems to reduce unstable angina and hospitalization for it, so by 2%. But no effect on death, okay? So they didn't publicize that. They just said that in patients with neurovascular disease, PCSK9 with evolocumab significantly and safely reduces major events. Benefit, whatever that would be, was achieved with lowering the LDL cholesterol well below current targets, okay? So it is true what they say, but it's very, very expensive as well. So you need to spend $1 million to prevent one event, but not a death. So that makes it very expensive and difficult to use. So who do we use it on? Because we don't really have the randomized data to use it on large groups. So it's kind of reserved for patients who can't take statins. Now, statin intolerance is why it's been so pushed by, oh, you've got aches and pains, maybe you can't have statins. Then there's familial disease, for which we do use it for. And then this is in their paper, net high-value patients, whatever that means. Does that mean private patients? I don't know. But it's not effective, so it's a bit pointless. So that's the background, okay? So this has just happened, and this has come from NICE, and it says they approved the groundbreaking cholesterol-lowering drug, inclirisan. Now, inclirisan is a small interfering RNA, and it targets the same protein, PCSK9. Really strange, because there's no long-term data. There's no evidence at all, okay? But they've got this deal with Novartis, which makes inclirisan available at a discount price to the NHS. And it can be given in primary care twice a year with a high cholesterol if you've had a heart attack. It can be used on its own or with statins. So this is quite unusual because this is on the NICE guideline page. Now, remember, we said that we have to have data that proves that you prevent deaths. We don't have any of this, okay? And they say there's no data directly comparing them with other treatments, such as ezetimibe, alirocumab, or evolocumab. There's also no long-term data on cardiovascular outcomes. Despite these uncertainties, it's still considered cost-effective in people who previously had an event. And so NICE considers it acceptable. And then they say a clinical trial is planned that will look at whether inclirisan reduces cardiovascular events. Who needs evidence when you've got this kind of support? Sajid Javid, great news. We're going to save lots of lives. So this is really peculiar because this is a drug that is now licensed. So look at the drug tariff price. It's only £55, which is not that expensive, really, compared to statins. But the real price, if you're a private patient, you pay £2,000. So what happens is, if I prescribe it in the hospital, we pay £55, and then some secret deal covers the rest. And it's probably not £2,000. In fact, it's an undisclosed amount. So we don't know what the deal is. But essentially, we have got this, that we're using it, and we haven't yet got the evidence for it, which is a slight worry. And then this came out last week in the European Heart Journal, which looks at all these different treatments and benefits of it to statins. And then for heart failure, because of course they're trying to comply for life for heart failure, it seems that maybe it's harmful. This is a very early abstract, but I don't think we really have the data to be using inclirisan the way it's been licensed. And I want to stop there and see if anyone's got any questions or thoughts about what I've said. And thank you all very much for listening. So I don't know, but you have a good point. And that's why I do think we do need the randomized controlled trial data for inclirisan before we, I mean, this is a huge use in primary care. They're like making it slightly more expensive than the standard treatments. This is for 6 months of treatment, right? £55. So it's been very heavily underwritten by the NHS. And I really hope that he hasn't got shares in the company, because that would really upset me.
Maybe he saw the RNA technology and thought it would help with COVID.
You know, I have to say, if you look at the word, he's got the word jab in it here, right? A new drug, a new heart attack jab rolled out. Okay, that's the Express. So you're absolutely right. I think the jab mentality that they've had is out there.